Fazira Herina binti Rosli. Today I'm going to present the topic thyroid storm. This topic is part of the topic in my clinical practice trauma and emergency care. Alright. The outline of the presentation we are going through is first we're going to give a brief introduction about the thyroid storm, and then the anatomy and function of thyroid gland. Then we'll proceed to the causes and the triggers, the pathophysiology of thyroid storm, clinical presentation, diagnosis and differential diagnosis, complication, management, which is we give the stabilization of the thyroid storm, and then the management from the pharmacological treatment, and also the other intervention what you can do for thyroid storm. And then we proceed to the prognosis and follow up, and the last one I'm going to brief about my case study that I'm doing for this clinical practice. Alright. Now I'm proceed to the introduction of the thyroid storm. Thyroid storm, also known as thyrotoxic storm. It is a rare but life-threatening medical emergencies actually, and it's categorized by a sudden and severe worsening of hyperthyroidism symptom. And this thyroid storm happens when thyroid hormone are accidentally and excessively released into a bloodstream, that leading to the series of physiological changes throughout the body. Alright. The anatomy and function of the thyroid gland. Alright, thyroid storm happen, as I mentioned in the introduction just now, that thyroid storm happen when there are excessively release of thyroid hormone into the body. Alright, thyroid hormone is produced in the thyroid gland. Our thyroid gland is located in the neck and in front of the windpipe. Alright, thyroid gland produce thyroid hormone. There are two types of thyroid hormone, which is thyroidothyronine T3 and another one is thyroxine, we call it as T4. Alright, the thyroid hormone plays a crucial role in regulating metabolism, growth and development. That is why it is affect our body when there are excessively of release the thyroid hormone into the body at the same time. Alright, the causes and triggers of thyroid storm is firstly is because the untreated and poorly controlled hyperthyroidism, which is people who have overactive thyroid. Usually we will prescribe with the medication to control the thyroid hormone, and if they are poorly controlled and untreated or they are mismedication, thyroid storm can happen lah. And then thyroid surgery of radioactive iodine treatment, and abrupt discontinuation of anti-thyroid medication. This is what I'm saying just now. Alright, the other causes and triggers is the stressful event, emotional or physical, such as infection, trauma or emotional stress. It can trigger thyroid storm. Right, the other one is pregnancy and childbirth also can trigger the thyroid storm. Alright, now we proceed to the pathophysiology of thyroid storm. How the thyroid storm happen? Alright, thyroid storm occurs when there is an excessive release and circulation of thyroid hormone, as I mentioned before, and it because of the elevated level of thyroid hormone affect various body systems, including the cardiovascular, nervous system, and gastrointestinal system. And it increase metabolism, heart rate, and sensitivity to the catecholamines to contribute to the systemic effect. That's why thyroid storm is important to be controlled. Alright, now the clinical presentation of thyroid storm. Typical symptom of thyroid storm, usually they have high fever, usually high up to 39 to 40 degree. And then the cardiovascular manifestation such as tachycardia, they can have palpitation, high blood pressure, chest pain, and also heart failure. And then there are also profound weakness and fatigue because of the thyroid hormone. And then they also can have altered mental status such as agitation, confusion, and then delirium. They also have the gastrointestinal disturbances such as nausea, vomiting, and diarrhea. By recognizing this symptom is probably crucial for early intervention because it can lead to severe causes lah. And then we proceed to the diagnosis and the differential diagnosis. As thyroid storm affect the metabolism of the body, so it may have a differential diagnosis with other disease. Alright, the diagnosis of thyroid storm involve a combination of clinical assessment and laboratory test, which is all the symptoms that happen to the thyroid storm patient should provide with the blood test result for the T3 and T4 level. And then the clinical assessment include a true physical examination and detailed medical history, which is we have to go through the detail of the patient medical history to know that if they are actually have the thyroid hypothyroidism or anything. And then the laboratory tests, as I mentioned before, may include thyroid function tests, including T3 and T4, as well as marker of organ dysfunction. Alright, the differential diagnosis that we can include is sepsis that related to the systemic inflammation, cardiac emergencies such as heart attack, congestive heart failure, and also SVT. And the other endocrine emergencies such as adrenal crisis. The proper evaluation is crucial to differentiate thyroid storm from other these conditions, as we want to treat the thyroid storm and the other disease with correct management lah. Alright, we proceed to the complication of thyroid storm. Thyroid storm can lead to the severe complication including multi-organ failure such as heart failure, arrhythmias, and respiratory failure. Infections such as pneumonia, sepsis, and high fever. Central nervous system effect such as agitation, confusion, delirium, and also seizures can happen. And then the thromboembolic event that the thyroid storm can increase a risk of blood clot, then lead to the deep vein thrombosis and pulmonary embolism. And then the metabolic derangement such as hyperglycemia, lactic acidosis, electrolyte imbalance. And if it is left untreated, the patient might die. Alright. The management of the thyroid storm. Alright, now we proceed to the management that we want to stabilize the thyroid storm patient as soon as possible. Usually we admit the patient to the ICU or a specialized endocrine unit, and then a multidisciplinary approach involving endocrinologists, internists, and critical care specialists. We also do the airway management to ensure proper oxygenation and give fluid resuscitation to address dehydration, and the temperature control measures to reduce fever. Alright, the management from pharmacological treatment, usually we will give the anti-thyroid medication such as propionate or metimazole in order to inhibit the hormone synthesis. And then we give the beta blocker like propranolol to control the heart rate and symptom. And we give the corticosteroid such as hydrocortisone to reduce the inflammation and inhibit thyroid hormone release. And then the fourth one will give supportive therapy such as intravenous fluid and electrolyte replacement. And the last one, we will give iodine-based agent to inhibit thyroid hormone release and block thyroid hormone synthesis. Okay, now for the other intervention that we can do for thyroid hypothyroidism is phlegmapheresis or therapeutic plasma exchange to remove the circulation thyroid hormone, or we can addressing the underlying causes of thyroid storm such as definitive treatment of hypothyroidism such as radioactive iodine therapy or thyroidectomy that we can do. And the last one, we need to do a close monitoring of vital sign, thyroid function, organ function for thyroid storm. Alright, the prognosis and follow up with the appropriate management, the prognosis of thyroid storm can be favorable lah, as it is can be controlled and managed if we treat properly in a need of time. Alright, now the close monitoring and follow-up care are necessary to ensure optimal recovery and manage the underlying thyroid disorder. For the long-term management, involve treating the underlying causes of hyperthyroidism and ongoing thyroid hormone regulation. Okay, now I'm proceed to my case study that I'm done for this clinical practice is regarding Mrs. Chua Mena. She is a 50 years old Chinese lady presented to the emergency department of Hospital Sultan Aminah Johor Bahru with complaint of chest discomfort and palpitation. And then she has a medical history of diabetic hypertension and hyperthyroidism, which she had not been actively treated for the past 5 years. Which means that she missed her medication for 5 years for the thyroid hyperthyroidism, and she came with all these symptoms. And then she had recently received her COVID-19 vaccination and is a non-smoker. She has a regular follow-up at clinic Kesihatan Kempas Johor Bahru for her diabetic and hypertension. Alright, upon triage, the assistant medical officer that noted that her chief complaint was chest discomfort and promptly conducted an ECG. And the ECG revealed an abnormality with a heart rate of 170 beats per minute, indicating supraventricular tachycardia (SVT). As we see from the ECG, it looks like SVT. So we bring the patient to the red zone for the further evaluation lah. And then during the assessment, Mrs. Chua Mena reported that she's experiencing shortness of breath, cough, fever and loose stool over the past 4 days. And however, the sudden onset of the chest discomfort and palpitation occurs on the day of the presentation. Alright, and then she appeared alert, conscious and oriented, but was tachypneic lah. And she also tachycardia and had a warm pulse. The capillary refill time was less than 2 seconds, and she was able to obey command and speak in full sentences. Her lung examination was revealed a rhonchi on the right side, and her abdomen was soft without tenderness of bladder edema. Okay, the vital sign of Mrs. Chua Mena is her blood pressure is 190/102. Her pulse rate was 170 beats per minute, and respiratory rate 30 per minute. The oxygen saturation on the room air is 96%. Her temperature was 38.8 degree, and random blood sugar was 16, and the GCS was full, 15/15. What the management and the treatment we give to the Mr. Chua Mena was, we brought up the Mrs. Chua Mena and continuous cardiac monitoring. And we keep the vital sign monitor and keep the SpO2 95%. And then first we give the adenosine 6 mg, 12 mg and 12 mg. We give 3 doses lah. To treat for the SVT first, and then we give the nebulizer salbutamol for the rhonchi and the IV hydrocortisone 200 mg to reduce the inflammation, and then the tablet propranolol 4 mg stat for the hypertension, and then for the thyroid hormone we give the Lugol iodine 6 drop stat, and we give the tablet Thyrosil PTU, we call it PTU 300 mg stat, and we give IV Augmentin 1.2 mg, and with the TDS in ward lah, continue. And then we give lactic cocktail ×1 stat, and IV pantoprazole 40 mg, IV drip 3 pints over 24 hours, and then we refer to the cardio and medical when patient is stable. Okay, the conclusion is Mr. Chua Mena case highlight the potential risks of associated with uncontrolled hypothyroidism, and the importance of regular medication adherence. The timely recognition of sign and symptom along with the appropriate administration of treatment of thyroid storm can lead to a positive prognosis and help prevent severe complication. Healthcare personnel should maintain a comprehensive understanding of the manifestation of thyroid storm to ensure early intervention and optimal patient outcome. Alright, so that's all from me from the Thyroid Storm. Thank you.